All right. So today I have like a legend in our field, Dr. David Tiberio. Uh, Dave, can you like introduce yourself a little bit for, especially for my audience there in Asia?
Absolutely. Eric, first, thanks for allowing me to be on your podcast, asking me to hopefully contribute something. I'm getting old now, but I've been in the movement world for quite a while. I started out primarily as a physical therapist and completed that training way back in 1973. And since then, I've done a master's and then a PhD in sport biomechanics. Uh, Taught at a university, which is something that you want to get into a little bit, for 26 years at the University of Connecticut. And then in 2007, I left that to work full time with Gary Gray at the Gray Institute. And although that's now been close to 20 years, we have this program called the GIFT program, and this year will be 2026 will be its 20th year. But I've been doing continuing education seminars with Gary since 1984. So it's a bit back and sort of have been in the traditional teaching realm. Also ran a biomechanics lab for a while at the university within the physical therapy department. And then a variety of things. That's what I've always liked, being able to have a variety of things to do in my job. And most of it has always been working with, if not patients initially, now it's more with students and getting into physical therapy. And now it's with people who are out there practicing, working with clients every day, whether it's strength and conditioning, athletic training, uh, physical therapy. I guess diversity is something that's important to me.
Nice, nice. So, uh, you mentioned that you were teaching in like University of Connecticut. So, what got you into like working with Gary Gray at the first place? Because it's like in my from for me, it's like it's very different, right?
Yeah, for your people who are listening to this, I guess the difference is that at the Gray Institute, with what we call the applied functional science approach, you see, we treat and assess the body as an integrated system, where in the traditional training of almost all movement specialties, maybe the osteopathic world's a little bit different, but for the most of the training, it's in an isolation mode. You learn as much as you can about the knee or the ankle or the shoulder. You learn as much as you can about a particular muscle. And hopefully there's some calls coming in here, but hopefully I'm not. We're talking about, the difference between what people might perceive as a traditional approach to a lot of things, and that would be, looking at different aspects of the body, whether it's a joint or a muscle in isolation, like training the glutes versus having the gluteal muscles be more activated and strengthening them through a global movement. So we can isolate out a particular joint or a particular muscle, but as Gary would say, it's always through an integrated isolation, meaning our goal is isolation, but while that part is integrated with the rest of the body, because that's more functional and that's how it's really going to learn to work the way it should. And that leads us to what we'll probably talk about a little bit later, in that, well, what tells it when to work and when to turn on and how many motor units to contract. And that's the proprioceptors. And so if we're not doing something that's uh, functionally consistent with what the person desires to do, then we're creating a gap between whether a muscle contracts or a joint moves. We're creating a gap when we isolate, and we hope that that gap is filled in when that joint or muscle is now part of an integrated system that's performing a movement like jumping or reaching or hitting a tennis ball or whatever. And so that gap is a challenge to all of our clients. And the more we can be close to the function in our assessment and our training and rehabilitation and injury prevention, the easier it is for the body to bridge that gap. and the more successful we're going to be.
Nice, nice. So, uh, you mentioned that you work with college and you also run a biomechanics lab. You work with Gary Gray for a long time. So, um, in the membership, you talk a lot about like the proprioceptor, which if you look at like maybe most of the courses in like strength and conditioning, most of the courses in physical therapist, there's not a lot of, maybe I'm wrong, but there's not a lot of like people talk about like proprioceptors besides like Golgi tendon organ like muscle spindle. So, but why you spent so much energy and so much time explaining about like the importance of proprioceptor?
Well, sure, that's actually a very good question. Not an easy one to answer. You're almost asking, why did that become a focus of ours at the Gray Institute? And it does go back a little bit to what I talked about, the isolation of something away from its true function versus integrating that part with the total function. But um, the challenge for us as all movement people, strength and conditioning, athletic training, rehab, physio, is that we have to move the client from where they presently are, whether they're somewhat successful or not successful at all, and we have to get them to the place where they can successfully complete the movements and the tasks of daily living that they want to do. So why do we focus on the proprioceptors? Because we, again, with the proprioceptors, it's more, they're turned on through movement. So we would say uh, movement lengthens the tissues, that turns on the proprioceptors. Therefore, that provides information for the body of what it needs and how hard a muscle needs to contract or how fast a joint needs to be decelerated, etc. And part of the challenge that we often in the movement world, and I'm guilty of this, we forget about is that what the body tries to do, and this goes back to a Russian physiologist named Nikolai Bernstein, but he talked about reactive forces in the environment, gravity, ground reaction force, mass and momentum, even the strain energy that's created when we lengthen a fascia or some tissue. There's energy that's in there. And what the body needs to do if it wants to be not only effective at completing a task, but efficient at doing that, meaning being able to do it over and over or being able to complete it with the minimum amount of energy expenditure, the body needs to be able to measure what's going on. It has to be able to know what's happening. And that's what these proprioceptors do because proprioceptors are nerve endings that contribute to our sense of where the body is and how it's moving and where it is in 3D space. So that's proprioception. But another term for them could be mechanoreceptors. So there are physical forces within the body that when they reach a certain level are going to exceed the threshold of a receptor and it's going to fire off an electrical impulse. Now, not one, but hundreds and thousands and millions. And so, what does the body do with that information? And so, if we go back to the reactive forces, all we want the body to do is provide the minimum amount of active force to combine with, to complement all of those other reactive forces in the environment. So when we combine the active with the existing reactive, now we get success, but efficient success. We're not wasting energy. We're providing all that's necessary, but no more. And that's really skill acquisition. When you get to be something good, you're not only effective at doing something, but you're efficient that you become skillful at it. Someone might say, well, they're agile. So they're able to respond to those reactive forces in the environment and then be able to add to that just the right amount of muscles across all these joints in order to execute a force. So I don't want to go on and on, but if you were to say something like, Michael Jordan, when he was playing basketball, was falling backwards. And he was about a foot from the floor, and he flips the ball up, and it goes in the basket. Well, you can either take the approach that he must have practiced that 10,000 times in order to be able to do it with that whole you got to do 10,000 hours or 10,000 times, or you could say that he had certain skills that when he uh, applied, was able, one, first of all, to perceive what was going on, to be able to see how gravity was even changing, and then measure those forces in the environment and add just the right amount of his own forces to execute the shot and make it go in. Now, do they always all go in? No, but the fact that the person of that great talent can do that, you can't tell me they practice that shot. They just, they don't do that. It's not you practice everything. So that goes back to motor control. I don't know if we want to get into this today
Sure,
or,
sure, sure.
well, most people, again, we're back to this. Well, if you get really good at something, you have to practice it for 10,000 hours. Well, there's no doubt practice helps. And there's no doubt that the more we do something, the stronger our ability to execute that task becomes. But without a lot of variety and variability, that task, although successful, is very rigid. It can only be executed when all of those environmental forces, the position of the body, the starting position, are the same. And so, what happens when you're starting in a different position, or there's a force applied to you from somebody else when you're playing a sport? Or so there are a lot of changes in the external conditions of the environment that if you don't practice a variety of things, then what's going to happen is you're going to have trouble executing outside of that one particular situation. So let me tell you a story and then see if this makes any sense. Uh, the faculty people that I was fortunate enough to study with at the University of Connecticut when I was doing my PhD, they were in motor control, and they call it's the perception in action, it's dynamical systems, a lot of fancy terms. You know, you can go deep, deep, deep into it. But the point is that in this particular study of speech, so these researchers with people at Yale did it. This is a long time ago. This is not a recent study. What they did was they were studying the articulatory movements of everything that's happening in the mouth and the throat and the vocal cords, etc., to say these syllables. So what they had these research subjects do is say two syllables that sounded somewhat alike, but required totally different coordination of all the articulatory structures. So someone who's listening might say, why are you talking about speech? There's no more complex motor act than talking. Think about it. You are producing different sounds and words based on muscles, joints. The vocal cords. It's a motor act to be able to say anything, and probably the most complex one. And so in this study, they wanted to look at, well, what are the subtleties of saying these syllables that are somewhat similar but require something different? But here's the real key. What they did was, as the person was about to say it, they were in an apparatus that hit their jaw. It perturbated their jaw and did not allow them to execute the word the way they would like. It interfered with what we would call the synergy, the organization of all the parts of articulation, the tongue, everything, all the parts of articulation are organized to say this word. There's a preferred way of doing it. The body does it a certain way. When they hit that jaw, they interrupted that. But here's the result. The person was still able to say the syllable accurately, and even more exciting and scary at the same time is that the adjustment that the body made occurred in less than 30 milliseconds. Now, 30 milliseconds is the time of a single reflect arc when you're in the doctors and they hit your quad tendon, your patella tendon, and your knee goes out. Well, that's a quick stretch to the tendon with the little hammer. It goes up to your spinal cord, it comes back, and it kicks your knee out. So that's 30 seconds. These adjustments were happening in less time than that. So the idea that this is a stored program that's really up in your brain somewhere and you just execute it and it just comes out is false. It just can't be. You can't have, 50 million different programs for every variation of executing something. Think of a tennis player about to return a serve from his opponent. And the first thing he realizes the serve is going to the backhand. Now, that player has what we might call a ballpark set of states that says backhand return. So they're going to get ready to execute what's needed for a backhand return. If I'm right-handed, I'm not going to turn to the right, I'm going to turn to the left. So there's a general ballpark. But meanwhile, in real time, as I see how much spin there is and the angle of that ball, I have to create a whole different synergy in order to get to the ball and hit it. And I can't call up backhand return number 6,458. It's not done that way. And so once that influences why it's so important to understand the proprioceptors and take advantage of them, but it also informs us as movement specialists that when someone is finally able to do something successfully, our job's not done. What we have to do is then introduce variability so that the execution of that task is what we might call more robust. It can still be successful in a variety of conditions.
Nice, nice. I love it. I love it. And uh while you're sharing this story, in my mind I was like I was thinking there's something else that like uh I, I kind of think of is when people rehabbing from like ACL, um the traditional like PT or uh traditional surgeon, like they want to start with like non-bearing. They want to protect the knee. But there's other like coaches who start like weight bearing, try to introduce function, try to do walking and like maybe like a little like lunges, a little like assisted pogo for athletes, of course for
Sure.
athletes.
Or for everyone.
Yeah. So, and they think that like by introducing like function first will help them recover faster, help them get back to playing faster. And I think it kind of coincides with what you said, like introducing function, and especially for those like proprioceptor to train the movement, to train the brain. I don't know if I'm making sense or not, but
Yes, you are. And I think that the cool part is that is a very big question. How soon, let's say you've had an ACL reconstruction, how soon should I allow you to go back and start doing things? Well, at the Gray Institute, we would say right away, but not everything right away, certain things right away. Now, why would we say that? Well, if you look at all the research on grafts, they obviously don't have a blood supply. They die, the blood supply has to come in. It has to heal, it has to take away all those dead cells that were in that tissue graft, replace them with all new ones. Wherever the screws are in the bone, that has to heal. If you wait until that ligament is completely healed, you would be waiting months and months and months. The other problem when you have is that tissues, whether it's ACL or MCL or any tissue, heals according to the stress that's applied to it. So even if you waited that long, the tissue would be weak. And so you'd have to go really slow. So what Gary Gray would say, he's going to begin rehab and he's going to be aware of the stress on that ligament, but he's going to rehab it as if he's not counting on that ligament. He's going to do things that protect the knee initially by bringing in all the friends to the knee, to the hip, the thoracic spine, the calf muscles, etc., and protect it. So that would be a way of protecting it while integrating it, not protecting it while making it not do anything. And then once the person is good at that, now we start to even challenge the knee even more and gradually stress that ligament even more by taking away some of those friends. So there's a process of adding in different components of the body, and then there's a process of taking that away. So we start with the isolated integration. So it's protected, but it's integrated with the body. And then we shift to the other side of it where we say it's integrated isolation. But you just can't wait that long. And not that we're geniuses or anything. The first place we learned that is when they were doing all these Olympic skiers and they were doing ACLs and they'd put them in a cast, which was stupid. They way back when, based on I can get into that, but what happened is the skiers ripped the cast off and started walking down mountains and then running down mountains and hopping and single leg stances and lunges. They ignored the medical advice of the surgeon and showed that they were much better off and much more advanced if they didn't follow the protocols. So it gets uh, sometimes there's information. I'll give you one more story and then I'll be quiet for a while. Sometimes there's information that is truth, but it leads us in the wrong direction. So that came out of the original ACL studies that said the ACL was most lax, least tension in 30 degrees of knee flexion. So after they did the surgery, they would cast these people in 30 degrees of knee flexion for at least 6 weeks, maybe longer sometimes. And then when they came out, then they had to get their motion back. They hadn't been doing any weight bearing. Their quads and hamstrings and everything else was weak. But the worst part of it was that if that ligament healed in that shortened position, that the only way to get full knee range of motion is you would have to stretch it out. So it just when you look at it was a true fact, but it was the effect of that set people back for years and years and years. So now we just don't do that. We're just more active. We just know there are certain things that you don't want to do early on. Um, like if you were to go and do a Gray Institute hop matrix, there are certain directions that are more dangerous than others. So you don't do all 6 directions. You do the ones that can build the quad and the calf and the hip muscles without necessarily going in the direction and making the knee go through motions that are stressful on the ACL.
Nice, nice. This is perfect. I love it. I love it. So, uh, followed by like the ACL story you shared, I think this is actually perfect. Uh, I think NBA, Major League Baseball, NFL, they're all like looking to like most of the team are like creating their own biomechanics lab and they're looking to all these like biomechanics to like try to prevent injury or try to understand why it happens.
Yes.
So, talk to me about like your experience with running a biomechanics lab and especially like nowadays in pro sport, everything is like research driven. So a lot of it solely focus on if it's like knee injury, they solely focus on knee. If it's hamstring injury, they solely focus on hamstring. So like kind of can you like share your experience with like these biomechanics lab and like what are some things we should look into when it comes like understanding these like mechanics, injury mechanics?
Yeah. A lot can be learned from the three-dimensional motion analysis. A lot can be learned from the force plate data. The problem is, what do you do with all of that information? Analogy was probably 40 years ago, they started designing these big biomechanics labs in children's hospitals to look at, gait in children and people who might have cerebral palsy or other things. And when I was living and working in Connecticut, they put a new one in there, and all the doctors would send their clients, and they'd come back with like a 40-page report. And it was just confusing and meaningless to the doctor. It was data, but it didn't mean anything. It didn't what was the local physician supposed to do with that information? And to some extent, it can be the same thing in sports. Um, but it doesn't mean the data is not good. It means that you have to ask the right question and you have to ask it twice. You have to ask it when you're designing the research, and then you have to design it after you have to ask that question after you get the results. What does this mean? how does this influence what I do? It can be too much information, and it can be misleading if the research wasn't designed to be functional. Now, there's lots of injuries in the sports world now that are befuddling everyone, confusing everyone, whether it's now all these Achilles tears and the hamstrings are not getting better. So there's a lot of things there, but uh, I'm not sure we're training the people right. And when we do the research, hopefully it'll tell us whether we are or not, because they'll do some before and after. They'll have baseline information. But again, if the testing is isolated, then it doesn't tell us the information that we want. So you have to say, well, is it jumping? That would be great because you'd see the whole jump. You'd see all the contributions of the different joints and muscles. You'd see different loads. And so that's a functional thing that love to study that and look at all the results of that. See if people are predisposed to some of these injuries based on where they generate their function, but or their forces. But one of the things you have to realize that most of the tissues in the body are not prepared to withstand some of these forces that it's under. So a good example is in baseball pitchers, American baseball pitchers, and not necessarily cricket pitchers or bowlers as we'd call them, but they might get involved in that. But when we tear this ulnar collateral ligament and you end up having these Tommy John surgeries, well, most of the time the cause is going to be in the hip or the thoracic spine or somewhere else. So if the research can tell us where these deficits are compared to someone who doesn't have that injury, that would be great. But to recognize that, the forces are greater than the tissue can withstand. When they do the studies on, and again, cadavers, but if you would apply a valgus stress to an elbow to try to tear that ligament, part of the resistance to the force of throwing is in all the muscles. So, in all the flexor muscles. So, as someone fatigues and the flexor muscles do less, now there's going to be more stress on the ligament. Some of it is resisted by the opposite side of the elbow joint, the lateral side, where the humeral radial joint. And so, there's that ulnar collateral ligament cannot withstand the Newton meters of torque of throwing a pitch. Never mind 100 times, not once, if all the other pieces aren't there. And so you can see why if certain muscles fatigue and their contribution goes down, now the stress on the ligament becomes greater. And so those are the types of things that we can look at and say, well, where else in the body might we be suboptimal? And if we can start to identify those things, it'll help the individual. And then hopefully with enough data, we'll have enough similar individuals to be able to start to know what to look for to prevent those things from happening.
Nice, nice. So, uh, I got a follow-up question about the biomechanics lab.
Okay, I'm only going to warn you because I had trouble setting this up today for whatever reason. I hope my phone doesn't die out too soon, but my microphone's running through the power port. So if we have to, we'll come back and do this a second one. I'd be
Okay.
happy to sit down with you. But go ahead. Let's hope we make it.
So, with all these biomechanics like initiation, like uh apparently foot had like 26 bones in it, and there's like 52 bones in both feet. But when you look at those biomechanics like software, there's only 3 points, 3 dots in the foot and ankle.
Yeah. Depends on
And
depends on what model you use, and some of them go deeper than that to try to separate it. But you're right. At that level, you're treating the foot as a single solid block, which you're smartly saying isn't true. And therefore, that can give us the wrong results or be misleading in any event.
and also the spine and the pelvis. So I know in Grey Institute you guys call it like the Achilles tendon hip, and when I talk to like other like chat coaches or some physical therapists, they're saying like a lot of the Achilles tendon or like yeah Achilles tendinopathy, Achilles tendonitis or like Achilles tendon tear is probably because they have something going on with their SI joint. And so, um, Why do you think you guys talk about the hip? Why do you think they talk about the SI joint, not like somewhere else?
Well, it's a good question and don't have the answer to that, Eric. We know the SI joint is an important source of pain and then therefore can be an important source of inhibiting the body's function. But there's not very much motion that occurs there. It's very, very minimal. And so when someone's in pain, we want to be able to try to fix that, but we want to look at what forces are creating abnormal stress that would force the ilium or movement on the sacrum to be excessive. And there's got to be a tremendous force that goes through that. And Gary Gray would say that's the crossroads of the body where all the forces go. But we would probably not focus on that as the primary place where the dysfunction is, but the symptoms there are being a result of abnormal forces somewhere else, whether it's a rigid foot. Just think if you had a rigid foot, it wasn't absorbing any shock, it wasn't allowing the knee to flex and therefore absorb shock, and all this shock was going up, goes through the hip joint and goes right through the SI joint. And all of a sudden, I might have an upslip or something that someone would refer to. And I've got this SI joint dysfunction. Well, yeah, it would be nice if I had manual skills to fix that, but it's going to keep coming back unless you go to the cause of it, which in this case, in this made up scenario, is the foot. But it could be anywhere. And so that's why we're not going to focus a lot on there. We may get into trying to restore that, but we know that that's not the cause of the problem. Now,
Mm.
there is an exception to that in some women, or if we have a hypermobile situation after childbirth and the hormones that allow the ligaments to extend more, then we can have a hypermobility. And sometimes there's a traumatic injury that causes a hypermobility. Now that's a challenge, very difficult to fix, but otherwise that's a source of pain and dysfunction, but not the cause of that.
Mm. All right, last question before I let you go. Um, People nowadays are talking about fascia training. They think they can like there's something called like they separate everything else but training only the fascia.
Yeah.
Which I don't know about how I feel about. I don't know how I feel about that. But uh, well, I learn more about like this proprioceptor and like all this fascia. It seems like the more we go to this end range of like transverse plane or like rotational movement, the more we can like involve fascia.
Yeah, I've got a deal for you because I know this silly phone is going to die. And I love the topic of fascia, and it fits with the proprioceptors because there are three types of proprioceptors, at least three in the fascia. So you would do me a big favor if you would invite me back to do a talk just on the fascia and how what it connects and what it does and what we know about it. And we can then tie in a little bit more about the proprioceptors because the proprioceptors are really dependent upon function. One last thing, if you have a Golgi tendon organ that's being fired because it's being lengthened in the muscle and there's tension in it, the body's response to that information will be different depending on the position of the body. The information is the same, but once it gets to the spinal cord and does different things, the body's response is different. So we've got to dig deeper into the proprioceptors in the fascia. And I don't want this to die in the middle. So if you'd invite me back, I'd love to come back and talk about that.
All right, all right.